So narrative exposure therapy carries in its name the treatment method. Narrative relates to creating a narration, a story of your life. And exposure means going into exposition. Exposition, going out of the position you were in at the time of the trauma back then. And therapy, of course, the healing part, but it's not just in terms of psychological healing, very effective treatment. It also accounts for the human rights abuses that happen. Narrative exposure therapy started about 25 years ago. There were like three really, I think, ingenious people coming together. One is Thomas Elbert. He was a brain plasticity researcher, so he understood very much about the shifting of the functional and architectural changes that happen in the brain due to traumatic incidences. And then there was Maggie Schauer. Maggie Schauer was a crisis psychologist who had also been called to help in places like, for example, during the Kosovo War. So she brought that knowledge, as well as client-centered therapy, Rogerian therapy, which is based on verbalization of thoughts and emotions. Now, Frank Neuner, he had come from Berlin and he brought testimony therapy. He was a cognitive behavioral therapist bringing testimony therapy, a very important part, which later became narrative exposure therapy. This is the documentation and acknowledgement of the abuse that has been done to people. So these three people were in Constance at the university, and they were treating the first torture survivors. And at that time, because of the Balkan War and the help there, pretty soon they realized that it's good to be able to help one person in Germany in a practice, in a safe space, in a practice room, therapeutic room, but the task is much, much bigger than that. So at the time I was in Uganda, working in Uganda, and there was a portfolio Children in War. And this was, so to speak, bringing now narrative exposure therapy to a place of conflict and crisis where masses of people are affected. And this is probably the most important slide that you really need to remember. When we started doing interviews with these affected people, there were like 3,570 people in our interview sample. Some of them Sudanese refugees who had crossed over to Uganda. Some of them people in Sudan who had never managed to leave, even though there was a war. And some of them Ugandan people who had been at home receiving refugees and who had been abducted as well, a part of the population, actually a large part of the population, by a rebel group, the Lord's Resistance Army. So this was a very complex setting, and we interviewed a huge number of people to get a good idea of what these people suffer from and what they need in order to heal. And what we saw is that there wasn't a single person anymore who, after a certain amount of traumatic experiences, remained mentally healthy. So in this sample, it needed 28 types of traumatic events for the last person who was still resilient to break down and develop trauma spectrum disorder. So this phenomenon of the building block is one of the most important understandings we took away, that in terms of treatment, the idea of an index trauma or a monotrauma is really to be questioned. And as it turns out now, 25 years later, in the way we have done research, it doesn't exist. So we have never seen a single person in our large sample of people, or large groups of people that we have talked to and interviewed, that just had post-traumatic stress disorder based on one traumatic incident. There's just nobody there. People, of course, now, once they have been exposed to one traumatic event, they build up what's called a fear network. So these elements peritraumatically of what happens, the hot memory, the cognitions, the thoughts, the sensory perceptions, the bodily memory is very, very strong. It's in an amygdala-based network. A lot of elements of fear, of helplessness, of survival. And this network is tightly associated. What wires together, unfortunately. So if another traumatic event happens, it will bind itself to the same network if there are shared elements. And in the nature of trauma, the shared element is always, I am frightened, I'm out of control, and I'm helpless in that moment. So the new memory, the new experience, binds itself to the old memory network. In that way, what we see in our survivors is large networks of different type of experiences that people have survived. And so in a person who has experienced multiple trauma, maybe like you might see in a person who has to flee the home, a refugee. So there are different type of stones in this person's life of survival, but we would call that then classic post-traumatic stress disorder or developing trauma spectrum disorder. And then we see in complex PTSD people who have repetitively and prolonged experienced the same type of trauma over and over again. So we have the manifestation of two symptomatically different pictures all based on having been traumatized more than one time. Unfortunately, in our research, what we have seen is that if people are confronted with trauma during pregnancy, like a woman is pregnant and experiences interpersonal violence, maybe her partner is beating her, this has a tremendous effect on the child. Immediately, these children build up a high stress axis, and at the same time, the glucocorticoid receptors are changed in the way they're mutilated. So the child is born, there's a baby born with a brain that is ready for survival. And this has a very high cost on the development of this child. Now you have a mix of a mother who has been traumatized and a child who is very difficult to regulate. These children cry more, these children don't sleep well, these children might show hyperactivity symptoms. So you have this mix of a mother who has a very difficult time to bond to her child because she's emotionally maybe shut off due to post-traumatic stress disorder symptoms. And you have a child who is very difficult to regulate. So what you set into motion is this transgenerational cycle of violence, neglect and abuse, maltreatment. And unfortunately, you can see this not just in a family, but in entire populations. So whenever we have gone to a place of war, of conflict, or of mass crisis, what we see is not just the outside organized, maybe human-made violence increases. In the household, the family violence increases in the same rate. So we have a very complex picture of perpetration and of victimization going on. In our research now, what we have learned is that, very surprising for us at the time, we interviewed 1,200 children who were former child soldiers and who had been returned to a transit center. And what we realized is there's a ceiling. There's a ceiling to the PTSD symptoms a person can experience. And we were really not clear what that is, because we thought the more trauma, the more severity, the more hardship, the more the rise of symptoms. But we saw that quite a significant amount of children who had survived, who'd come back, didn't show classic trauma symptoms anymore. And then we discovered what happens if you humiliate and mistreat children early and threaten them with being killed, threaten them with dying of hunger or other forms of hardship. In their teenage years, eventually they will go into this, from a reactive cycle of violence where I'm trying to defend my life, into the appetitive form of violence, where they start now actively, aggressively acting out. And this gives them a sense of control. It stabilizes the symptoms. Trauma symptoms go down, but the appetitive aggression grows. So this is also a form of pathology that needs treatment. So when we conceptualized what we need to do, we realized we really need a shift in the paradigm of how we choose who needs treatment. We went away from looking at differential diagnostics of presentation of symptoms. For example, what can a person present with after having been traumatized? People can have post-traumatic stress disorder, they can have complex PTSD, they can suffer from appetitive aggression, they can have borderline personality disorder, they can have depression, trauma-related, suicidal ideation, they might have anxiety disorders, they might show panic attacks. Some people even have psychotic features. A lot of ill health in the body. As we know, people who have been traumatized in childhood have a very high likelihood to develop heart disease later, cancer, the likelihood is highly increased, diabetes, gastrointestinal problems, autoimmune disorders. So it's now the paradigm shift for us was, let's not just look at what people present with symptomatically, but we need to do, when we start with a patient, to do an intake on what happened to you. What type of experiences did you meet with in life? And based on that, now decide, do I need to do a trauma-focused therapy or can I do other types of treatment? And what is very important, what happened to you, it's probably did never start with you. It's a history of a collective or a history of your ancestors, your family. Narrative exposure therapy, a treatment that has to accomplish a lot of things in a really short time. Because at the same time as we realized what to do, we realized there's no people that have enough professional training to be at the level of, maybe a Western-based psychologist, psychiatrist, even nurse. I remember at the time, 20 years ago, we went to Eastern Congo, there was one psychiatrist and a psychiatric nurse available. So we had to compose the treatment of narrative exposure therapy in a very solid, robust, but simple way. So a person who has gone to school and can read and write primary school level can be trained as a non-expert to deliver this treatment successfully. So this is a challenge. It has been a challenge. And it has to be an approach that works universally. And now it was pretty clear that talking about what happened to you in life is a human universal. So oral tradition of sitting together and talking about what happened to you in life is, people have done this for hundreds and probably thousands of years. So this is a human universal to engage in a conversation. And this is what makes NET quite different to other exposure treatments, in that you stay in an exposure conversation. So it's not just like the patient or the client will work in exposure. You as a therapist are equally active. So there's one sentence from you and one sentence from the client and one sentence from you. So it's a tightly knit conversation. I always compare it to, let's walk the mountain. We have to come to the summit, which is probably the highest moment of fear for you. But we're going to do this together. I'm the mountain guide, but you know the way. So we need to stick together closely, right? I got the technical skills and you know where we need to go. So it's a technique that, of course, this is taken now from client-centered therapy, the very close, empathic, congruent, a close human togetherness. And then the exposure part, of course, Thomas knew from brain plasticity that we need to go back in imaginal reliving to what has happened. And we need to document what has happened, because being ill from a moment in life where a person was violating me, maybe shattering the integrity of my body, maybe trying to kill me, maybe neglecting me as a child, is a powerful experience of abuse, of human rights abuse, of women's rights abuse, of child rights abuse. And that needs documentation and it needs political advocacy. So all of this NET had to be able to do short sessions, not short session, the duration of a session is quite long, but the amount of session is reduced. Human rights-based, treating different types of traumatic experience, including moments of neglect, including moments of hardship in life, of social pain, and of classic trauma. It has to be disseminable to lay counselors, and now also it has to have an aspect which lets it disseminate through these lay counselors much further into the local structures of the community. So we need large-scale public mental health structures that are based on a tiered level. So let me just introduce you to the steps of how you implement this treatment. Step 1 of narrative exposure therapy is the face-to-face checklist interview. And I'm going to show you the checklists we use in a moment. But it's really important to understand that as I see the person for the first time, I'm going to sit down and we're going to go through a structured interview set, approaching the trauma material, already trying to put some words to it without going deep into exposure. Okay, this is more like a therapeutic session, not an exposure session, but we want to make clear it's time to approach trauma material now. We do measure trauma reactions, so we know, at least with a simple, like maybe the PCL5, so we know the amount of trauma symptoms the person is suffering. We also assess the amount of dissociation in daily life that is taking place, so that we are well prepared to know, as a therapist, what is coming my way, how much, I have to implement anti-dissociative strategies during the imaginal reliving. Based on the trauma reaction intake, I can now do a psychoeducation. Psychoeducation is short and sweet. It's not a full session of 60 minutes because in our experience, it will just blow past people's mind because they're so busy with coping with all that is happening within their mind and their body. So psychoeducation is like a 10-15 minute in the beginning, and then again and again and again as it is necessary. So one of the event checklists that you need to do if you want to do narrative exposure therapy in session 1 is the live event checklist. This is the classic trauma event checklist according to DSM-5. You can, of course, also do another trauma intake list if you want to, the PDS, for example. Then we had the great fortitude to meet Martin Teicher, a researcher from Harvard who compiled the MACE, which is based on the ACE scale of Vincent Felitti. So the adversity, maltreatment and abuse chronology of exposure scale, which is a wonderful tool to assess adversity and abuse in childhood. So we also do, when you do NET, in the session number 1, you go through the MACE. So the life event checklist asked about trauma in your entire lifespan. And now the MACE asks especially of experiences in childhood, 0 to 18. And it also takes care of what you might call sub-level trauma, and clinically speaking, moments of neglect, moments of social pain, moments of social stigmatization, of not being seen as a child, for example. This is the shutdown dissociation scale. It lets you dissociate at the same time the subtype, the dissociative subtype, if you want to do that. I think it's a very good scale to do in session number 1 as well, because it gives you a nice, in terms of a descriptive scale, a good idea of how people try to cope with dissociation in daily life. Trauma reactions, as I said, PCL maybe. Then there's a short psychoeducation, as you would always do. And now session number 2, step 2 of NET, session number 2 is laying the lifeline. So in the checklist intake, session number 1, we have taken care of understanding the adversity that people have suffered and survived. But by laying the lifeline, we are introducing other symbols as well. So we are introducing the flowers of life, which are resources, the moments of joy, the moments of belonging, maybe a cat or a dog, maybe a grandmother. So it's also time now to really make it visible there wasn't just stones in my childhood. Even if there are many, there might have been moments where life was really nice. You know, when one Christmas I got a present from my grandfather, and he would play football with me in the evenings when he came home from work. And then, of course, we also have in the lifeline sticks. Sticks are moments in my life where I have harmed or hurt, I have killed, I've injured, I've raped another person. So where I have committed an injury and a trauma to somebody else. We also have the candles as a symbol. The candles are a symbol of moments in life where I have lost a beloved person. You can put a stone, but a candle is much more of maybe a symbol that's more going beyond just the stony nature. It's also the loss and the memory of the person. This is session number 2, very important. We go chronologically from birth all the way through up to today. It's very interactive. Therapist is helping. And very important, this is again not an exposure session. We're going into an allocentric perspective. It's like as if a bird eye view flying over a person's life. And once it's laid and done, this is my roadmap. So as a therapist, I have my roadmap, and we are going to now take the road trip. We're going to travel to all these places. Now starts the actual process of narrative exposure, where we start at birth, and then we go through all these stones and flowers and sticks and candles that are laid out on a person's life. Very important. In one session, I do the exploration of the experience, and in the next session, at the beginning of next session, I will read back the testimony that I have taken. So this is really, really important, because now the imaginary reliving, the telling of the story is in an egocentric perspective. In the beginning of next session, I'm already, by reading it back, allowing my client to go into the allocentric perspective. The essay is phrased in the past. Sometimes we open it up again at the places where we still need to go deeper. Maybe I need to talk about the meaning in a place. Maybe I have forgotten the bodily sensations. Maybe I want to talk about how does it make me feel right now. So it's opened up again, becomes more comprehensive. And so we try to find as best possible all these pieces, all these fragments, to make it a full story, to bring the puzzle pieces together, to give the full movie of what happened in this moment in the past. And these essays, these narratives, then compose the full testimony of life. Also, we do the flowers, not just the stones and the sticks. How we process, remember we had to teach lay counselors on how to do an exposure. So we have turned this, the way we go into exposure is called the narrative exposure cycle. It's a very set way of asking your questions, of traveling through all these levels, of building a context, thoughts, emotions, bodily memory, the meaning of the past, shuttling to the here and now, how is this right now, summarizing, going back, moving on in the movie. So it's a very safe, very solid, predictive way of moving through the traumatic experiences from moment to moment. As I've said, in the next session, we're reading back, we're completing the narrative that was taken last time, and we move on the lifeline. In the end, we have a testimony. So a testimony, a written testimony, acknowledges the abuse that has happened, and it gives the dignity to the survivor of having had a human being listening and documenting all that has happened to me and guiding me through. Many people, even if they couldn't read or write in this world, there are quite a lot of people who have never formally gone to school. They still value this document because some people say, I want to show it to my children and my grandchildren to know what happened to us. You know, especially if you work in areas of mass crisis, where a lot of the population was affected by war, by massacres, by displacement. or the indigenous people communities. Sometimes people go to trial, go to court with their testimony, for example, if they seek asylum. Or we can also give it to the United Nations Fund for Survivors of Torture. This fund is really interested in knowing what type of abuse happens in what country in the world, what type of torture is done in what prison, and so on. Very importantly, and for us quite a new baby, it's not a baby anymore, it's already walking, is a new type of, how can I call this? It's almost like at a project level, community exposure. It's called net facts. So net facts is sort of telling the story of traumatized communities and exposing the whole community back to what individuals have processed in narrative exposure therapy. So it's a very, very interesting, very promising population-based approach where perpetrators and victim in a given community produce narratives about their own experience, about their life, and then we compose general narratives of victimization and of perpetrations. And then culturally, this is very unique to each setting. A type of community exposure is done to bring back the experience of individuals to the community, so that the collective, the cohesion of making meaning about what happened is all-inclusive. What we have today is a fragmented memory, a narrative of a population where only segments of society get a voice. And this leads to further and further societal violence. So we want to include the stigmatized people, we want to include the people who have fallen to the fringes of our communities, of our societies, and make their voices heard. And by that, diluting the black and white, the good and bad picture into a common shared past. Evidence that is an effective, efficient therapy. There have been a number of reviews and also meta-analysis now published. The type of narrative exposure therapies that are there, all of them at the core do the same thing. And all of them at the core do narrative exposure, classic, as I've just told you. But there is a version for children, KidNet, that has a component of bringing in, of course, the caretakers, and also for the children to work a little bit more with creative media in order to allow them the easier process of reliving. Then there's 4NET. This is for our perpetrators, for our forensic offenders, a specific type of narrative exposure therapy highlighting also the deeds, the commission or the omission of help or the commission of violence to others. And it also has a group module at the end. For you to know, of course, narrative exposure therapy, the individual is processing, is done alone with a therapist or counselor. And only after having processed, I can bring it into a group or share it with family or go into a support group. So we do not process the experience of the past in a group setting. Then we have NetFact. This is the community exposure. And then also there's a now efficacy found in a treatment called NetMed. We were quite overwhelmed with the number of people who came from intensive care after having survived Corona with post-traumatic stress disorder, which I think the practicing therapists in the Western setting is impossible to accommodate even more trauma survivors, such numbers. So we were teaching doctors in the family practice how to do a very reduced version of narrative exposure therapy. And it shows quite some significance. It's nice. This is just an image of where in the world NET is happening and with what type of communities, quite a varied group. There's probably even more. I've just tried to pin the ones that came to mind. So narrative exposure therapy takes place in many countries of the world with very different settings and very different populations. And because we are telling the story of people's lives, it's universally applicable and produces efficacy. So in a way, you could say it's the most simple method of treatment that exists, because all I do is I say, tell me the story of your life without omitting anything. And I'll be there to accompany you, to listen to you.